Hi.
Welcome. So, as you know, this is going to be run in Zoom. I suppose that you have, as everybody does these days, quite an experience with the software, but if you want to ask anything, I'll be happy to help you. And I would suggest that you would test your sharing so that we would make sure that everything is in place.
Yes, I was just changing my background to the non-room but official LUMC, which looks a bit nicer, I think.
Yeah,
That's
sunshine
better, right?
and all.
Yeah. Yeah, it looks about how it is today.
No, I mean your back slide is sunshine, your background.
Yeah, now it is, yes. Yeah, and it also looks about real today.
So good.
I was just closing every other thing I have open right now because it doesn't make a lot of sense to keep that open. So, and then I'll set this to hide presenter view.
Sorry, I was sharing the slides, so now you can share your.
Okay. I do this, and then I do share screen. Screen 2. Share. Can you see it now?
Yes, it's perfect.
Good.
That's fine. Do you want to leave this one, and perhaps we don't have to? We can keep the current screen and just wait for the start.
So just leave it like this.
Yes. I think
sure.
So. Okay.
If I can still mute myself, then yes, there, I guess. Yep.
So we still have 5 minutes, a bit more, so let's wait a bit.
Yeah, I think I'm going to turn them around because now I'm looking at the, because I won't be seeing any participants, will I?
I don't know. Don't you see the? You can see the participants by clicking on the bottom or on the top in your case, and there's a bar. In that bar, there is a button called participants. If you click,
attendees.
You see who's attending. At the moment, we are still just 4, but it's not still 4 o'clock. So,
yeah, I saw Pierre.
Yes, you have Pierre Carlier.
Yeah.
I'm going to allow him to talk if you want. Pierre, if you want, you are unmuted.
Yeah, thank you.
Hi, Pierre.
Thank you, Antonio. Hi, Herman.
I was just playing around with the screen, so I'm actually looking at you.
Welcome.
Thank you.
I spoke to Giorgio, so he agrees with everything. He will be happy to organize and lead the MRI versus NGS discussion.
Oh, okay, good.
So I think it's fixed. I have to discuss a little bit more with him and with you and probably together to see and to decide who's going to be in the discussion panel. I mentioned that Volker will certainly be part of it, and I would be. We decide, I think, to invite Carsten Bodman, and that might be enough. In fact, if we have the 3 of them, plus the people asking questions in the.
Yeah, are you aware that you're live broadcasting at the internet now? I'm just wanting to warn you that basically people can listen to what you're saying.
Yeah, well.
Sorry about the comment, but it was just to avoid any problems.
That's good because, we never know. And, but I think so far I just say nice things, so that's not too much of a.
I only see 2 attendees, so.
Yes, we have 3. Yes, but we are still ahead of time. So
yeah.
Ermin, are you ready? Can I start now?
Yes,
Okay.
sure.
All right. So welcome to the second of the summer school webinars for Euro-NMD in collaboration with the Rare Neurological Disorders European Reference Network and the Academy of Neurology, European Academy of Neurology. Today's webinar is about the validation of MRI as a biomarker in clinical trials. Ermin Khan from Leiden University is going to navigate us through this theme. We know that currently this is one of the more important biomarkers that has been used and is going to be increasingly used probably in the clinical trials in the future. And it has brought a new dimension for not only the diagnosis, but probably for the monitoring also of therapies. and it would be obviously a fundamental point for these summer school webinars. Ermin Khan works in Leiden, as I said, where she has important role in the MRI section of for neuromuscular diseases. And I thank her very much for agreeing to participate in the webinar, and give her the floor. Thank you.
Thank you very much for the introduction. I see lots of familiar names among the attendees, but also some unfamiliar names, so that's really nice. So again, thank you for the introduction and also for the invitation. I've given this lecture before in the summer school of Euro-NMD and the ERN, but I've updated it, of course, I tried to update it as much as possible with some recent data, but as was already mentioned, there are a lot of MRI studies appearing, so I already say sorry if I did not include your favorite study in the talk, but you can send it to me later, and then maybe next time I will. So as an outline of my talk today, I'll first give you some background on MRI. I know that there are several people in this webinar who already know a lot about MRI, but also to make sure that the people who don't kind of know what we're talking about. I will explain why we need quantitative MRI and why the appearance of quantitative MRI has actually enabled a lot of the studies and where we are right now in the development of MR as an outcome measure. I will explain the relation of the things that we have found to disease progression and to muscle function and daily living. I will shortly go into trial readiness, to the things that we have already done and a lot of people have already done. And then a little bit about the future, how we go from individual scientific studies to accepted outcome measures, because that is something that I really learned over the past decade that is much more difficult than I thought. So first, a little bit of history. I always like to include this picture, which is from the late 1970s, early 1980s. I must confess, I don't really know. But what you see here is a prototype 0.15 Tesla scanner from Philips on your left, which doesn't look at all like a scanner today. At least that's because we dress it up a lot more nicely. But you can also see the first brain scan of a patient in the LUMC in 1981. And if we would make a scan like this today, we would say the scan it's just not successful, but back then we were really happy that we could look into the brain. And this is actually back here. I put like a virtual background, but if you would look behind me, you would see almost see the door to our 7 Tesla MRI scanner, which is also still from Philips. And this is a high resolution brain scan we made here at the 7 Tesla in 2015. And I guess the difference between what you saw before is obvious. These are the only 2 brain images I'll show today. So for the rest, I promise that I will fully focus on muscle. So what is MRI? So MRI stands for magnetic resonance imaging. And what we do with MRI is that we image protons. So if we can imagine some of the protons here, I just made a cartoon here of the protons on top of a leg, a muscular dystrophy patient leg, actually. And if we would then put these protons into an external magnetic field, what would happen is that they would align to this external magnetic field with a proportion of the protons aligning parallel and another proportion aligning anti-parallel to the field. What we do then is we can send a radio wave into these protons, and what happens is that they tilt, right? They switch position. Then we switch off the radio waves, and then they fall back to their original position. And when they fall back to their original position, they send out radio waves, to send out energy actually. And this energy we can pick up with a local receiver. And this is the basis of MRI, basically. It's a very simplistic way of saying it. So I know that the MR physicists in the audience right now will probably cringe a little bit, but this is the very simple way of explaining MRI. So what do we need then? I told you in the beginning, we need a magnet, right? So this is a large 3 Tesla scanner, and 3 Tesla is a unit for magnetic field, basically for the strength of the magnetic field. And 3 Tesla, as you see here, is about 52,000 times the Earth magnetic field. So this is a scanner. Then we also need the antenna to receive the signal. As I said, once we've given some energy into the protons, they fall back, they emit energy when they fall back, and we need an antenna to pick up this signal. This signal, however, is not very strong. So we need this antenna to be as close to the tissue of interest as possible. So in this case, I said I wouldn't show any brain images anymore. That was true, but this is a brain coil, actually a head coil. So you would put your head in. What we would do for skeletal muscle is that we have more like a blanket type of coil that you put on top of legs or arms or wherever the muscles that you want to image. The scanner also makes quite a bit of noise. Those of you that have been into an MRI scanner will know this, and we need to protect the ears against this noise. So you also need headphones against the noise, and there's also a microphone attached to these headphones, so you can actually talk to the operator who's usually outside of the MR room. Right, so in summary, what do we do with MRI? We image protons. So we put a person into the scanner. The protons in the body emit signal, a proton signal, and from this signal we can do fancy mathematical tricks and we obtain an image. So what do we see on such an image? In this case, a muscle image. So this, what you see here, is a transverse slice through the upper leg. And what we see is the bone in the middle, right? You have one bone, one large bone in your upper leg, where the bone itself is black. And the white here is bone marrow fat. So that's bright in this image. This is a T1 weighted image, as you would say it. Then we see some blood vessels. We see all kinds of different muscles. So the quadriceps here at the front and the hamstrings at the back. And we see the subcutaneous fat, which is surrounding the leg, basically. So what are the advantages of magnetic resonance imaging? Well, I told you that we would send in radio waves. Well, these radio waves do not contain ionizing radiation, right? So we consider it a non-invasive technique because there's no ionizing radiation. And it has a very high spatial resolution. As you could see in the previous image, we could depict all the different muscles and we could even see the borders between the muscles. So you have a very high spatial resolution, as you would say it. There's a large imaging plane. Like if you compare it to a muscle biopsy where you take a very tiny sample from one muscle, here we can look at pretty much all the muscles in the body if you would want to. It's less dependent on motivation compared to functional tests, for instance, right? So if you would ask somebody to walk, as is a common outcome measure in muscular dystrophy trials, is walk for 6 minutes, especially in children, that's really dependent on motivation. I would not say an MRI is not dependent on motivation, because if you do not want to lie still, because that's a very important aspect of an MRI, is that because the signal is so low, you have to lie still for extended periods of time. If you do not want to lie still, the subject doesn't want to lie still, you would not get a good image. But yeah, as long as you lie still, it's not dependent on motivation. We can also do quantitative assessments. Right? So it's much more objective compared to a qualitative score of muscle force, for instance, or something else. And another big advantage, which I unfortunately will not have time to go into today, is that you can get multiple contrasts in one imaging session. And what do I mean with multiple contrasts in one imaging session? Well, that means that within one imaging session of typically a half an hour to an hour, we can get measurements of muscle or cellular size. We can look at fatty replacement. We can look at edema or inflammation, or at least get measures for edema and inflammation. We can look at cellular damage. And yeah, we hope that we can look at fibrosis, but that is still something that is under development. So why are all these contrasts now so important? Well, it's because the disease cascade in neuromuscular disease actually has a lot of these aspects that I just mentioned involved in it. So if you would have a healthy muscle, like all of us hopefully have, we exercise or we do something for which we get muscle damage, then from the healthy muscle, we get muscle damage, you get inflammation. Oh, that's what I see. You get inflammation and regeneration and transient collagen deposition. But then in a healthy muscle, this is a circle, right? So the muscle repairs and you have a healthy muscle again. So what happens in muscle disease? In muscle disease, one of at least the hypothetical pathways is that you get a persistent inflammation, right? And if you remember the previous slide, inflammation is something that we could look at. Due to this persistent inflammation, you get fibrosis, fatty replacement, and changes in fiber size. This will all result in less muscle recovery. And due to this reduced muscle recovery, you get a loss of muscle fibers and muscle function. So indeed, if we look on histology and histological slides from muscle biopsies, what you see is changes in muscle and fiber size. You can see edema and inflammation. You can see necrosis. You can see fat replacement, and you can see scar tissue. And I've included two histological slides here, where here you see the fat replacement. You can also see that, sorry, I should have included a healthy sample, I now realize. But normally in a muscle fiber, you can see that it has all sharp edges. Basically in here, it's all rounded. You can see that the fibers are not all of the same size. And here on this biopsy sample, you can see some fibrosis and edema and inflammation. So if you come back then to the contrast that I just mentioned and the role for magnetic resonance imaging, you can see that actually many of the aspects that are mentioned here in the disease cascade can be measured. Again, in the interest of time, I will only focus here on fat replacement and on muscle size, also because these are the techniques, or these are the aspects that have been looked at the most. But if you want to know more and look into the literature, there's actually a lot of other imaging techniques being used in neuromuscular disease. So many of the techniques that I will mention today are the Dixon technique, or fat water imaging, and also proton MRS. So as I mentioned in the beginning, the step to quantitative MRI has actually enabled us to do a lot of the correlations and associations that I will show later on. But what is the difference between, what do I actually mean with quantitative MRI? So in conventional MRI, as we would call it, we would get a T1 weighted image, which is shown here, of a patient with Duchenne muscular dystrophy. What we now do with quantitative imaging, when we use the Dixon technique at least, is that we obtain a fat image and a water image of exactly the same tissue. And you do this within one sequence, so they're not two separate acquisitions. You do this in one sequence, and I will not explain why. There are enough reviews about it, and it's a little bit beyond the scope of this talk. So the main thing is that we obtain a fat image, we obtain a water image, and and with these two images, we can obtain the fat fraction of a specific region of interest. So one of the first things that I did when I started working in Leiden, is my first PhD student, is to actually compare a qualitative scoring, as was still conventional about a long time ago, but it is still being done a lot because it's a lot faster also to actually look at images like this, is to look at the qualitative scoring that was done, where you basically score a muscle with a 1, which is a normal muscle, a 2, fatty streak, so that's about less than 15% fat, 3 mild changes, which is less than 30% fat, 4 is moderate changes, which is between 30 and 60% fat, and 5 is severe changes. So we asked 2 of our radiologists to score these images on this 5-point scale, and then we made, from the same region of interest, we made Dixon images, and then we compared their scoring to the fat fraction. So you can see here, for instance, that this muscle was semi-quantitatively scored as a 2. So that would mean less than 15% fat, where indeed the quantitative Dixon images showed that this muscle had 6% fat. This muscle, however, was scored as a 5, so severe changes, over 60% fat. Well, actually, if we quantified it, it only showed 26% of fat. So you can imagine, if you looked at these images, that when we sum all these results together, that a normal muscle will be also normal on a quantitative fat percentage score. But you can see that even though it's correlated, right? So a more severe muscle on the qualitative scoring is also more severely affected on the quantitative aspect. But you can also see that the range at the qualitative scoring, the range in fat fraction in a score of 5 is huge. Right? And then if you want to test a therapy where there's only a couple of % change in fat fraction per year, a scoring of 1 to 5 will not get you there. It will never be sensitive enough to score the effect of such a therapy. I put the original reference here from Beatrice Roque, which was my first PhD student. And I know that many, many, many other people have shown this. So it was not our radiologists that weren't very good at scoring. It's a general finding, and I did not put all the references here, so I'm sorry if you miss your name here. So what does this tell us again? So I've added an image here of FSHD, so facioscapulohumeral dystrophy, and an image of a Duchenne muscular dystrophy patient. And where previously we could only score these images on a scale of 1 to 5 or 1 to 4, there are different scales out there, we can now actually put numbers on here, right? So this muscle is 8% fat, this muscle is 80% fat, this muscle is 30% fat. Another thing that stands out on this image, at least for me, is that it's very different, right? It's not the case that in every single neuromuscular disease, the same muscles are affected. Here, the rectus femoris has 30% fat. I didn't put a number here, but here in FSHD is actually affected less. The difference is very apparent here at the hamstring. So at the back of the leg, where this whole posterior compartment in this FSHD patient is almost completely gone, while in the Duchenne muscular dystrophy patient, there's still quite a bit of muscle left. While in contrary, here at the front, this Duchenne muscular dystrophy patient has 65% fat, while the muscle here, the vastus lateralis, is preserved almost completely in the FSHD patient. So this is something that will come back later, but the muscles that are affected differ quite a bit between the different diseases, and we don't know why. So we've shown now that we can quantitatively measure the fat in a single muscle. That's all really nice, but if this fat fraction does not correlate to function, it doesn't serve a good purpose as a biomarker, right? Because in the end, for the patient, what is most important is daily life function. So a biomarker needs to at least be related to function somehow. So I've lined out a number of different studies. So this again is an example from our own lab, from Beatrice Wocke, where we imaged excuse me, a number of different boys with Duchenne. So this is not the same boy aging over time. These are all different patients with Duchenne muscular dystrophy, where this boy is the youngest, a 5-year-old, and this is a 15 or 16-year-old, if I remember correctly. And what you can see that over time, the fat fraction increases. And you see that because the muscles are becoming more and more white. Right, so it's more and more resembling the subcutaneous fat, which is outlined and the outside. So what you can also see, because it's a Duchenne muscular dystrophy patient, is that there's typical hypertrophy. So bigger muscles at the back compared to the front, and that is actually also preserved until quite late. So the increase in fat with disease progression and the increase in fat with age is not particular to Duchenne, of course. There are many different muscle diseases, and many of them are progressive, slowly or fast progressive. This is an example in LGMD2I, for instance, where these are patients of different ages or different disease stages. It's not really stated in the paper, at least not in the figure caption, where in this patient A, there's hardly any fat replacement, while in patient E, there is a lot of fat replacement, right? And here it also seems in LGMD2I, here it also seems to start in the hamstrings more compared to the frontal compartment. In the study by the group in Nijmegen, you can see that in myotonic dystrophy type 1, the fat fraction of the muscles is actually correlated to a clinical score. So the MER score is a clinical score in myotonic dystrophy. And you can see that patients that have a higher MER score, so are doing worse basically, also have a higher general fat fraction. The other thing I just mentioned in the image that I showed of FSHD and DMD is that the increase in fat replacement varies between muscles and it varies between patients. So this is an example of Melissa Hoijmans, who's also one of my former PhD students, where she looked at the different muscles in the lower leg, so in the calf. So we can here see the gastrocnemius lateralis, for instance, where all the black dots are healthy controls, which we measured over time. So we measured every patient and every healthy control 3 times. So at baseline, at 1 year and at 2 years after that. And you can see that all the red dots actually increase in fat fraction over time. This increase, however, differs between the different muscles, right? So we can see that the gastrocnemius lateralis in this boy of about 10 years old is already at 60%, while in the same boy, the tibialis posterior muscle, which is still here all the way in the middle, is actually still quite low. But all the muscles seem to show a similar curve. So the imaging DMD group in Florida showed the same thing and showed it earlier than us. So maybe I should have shown it first, is where they specifically looked at 2 different muscles because they did not use the Dixon technique. They used MR spectroscopy, and they looked at the soleus. So that's a muscle in the lower leg here at the back, and the vastus lateralis, which is a muscle in the upper leg. And here you can also see that in the different age groups, the number of the amount of fat increases, right? So these are all the controls in light gray that you can hardly see, and DMD baseline and DMD 12 months. So you can see that it increases, but you can also see that in the vastus lateralis, the fat fraction is actually much higher compared to the soleus, which is also something that we see in these images, right? So the upper leg is affected before the lower leg, which is also something that we know clinically. Also in other muscular dystrophies, the increase in fat replacement varies between muscles and varies between patients. So here in the study by Wang et al., you can see that the fat fraction change, which is on the y-axis, is shown for different skeletal muscles of both the upper leg and the lower leg. And you can see that the fat fraction change has quite a high range, right? Some muscles actually decrease in fat fraction and some muscles increase up to 20% or even up to 45%. Sorry, that's not 45% in 1 year, 4.5%. And also in LGMD2I, you can see that the change in fat fraction, so this is a study by Murphy et al., that the change in fat fraction over 6 years, so this is quite a long study. So this is the 0 line, at 0 where there's no change, you can see that pretty much every single muscle, so all the muscles are lined out here on the y-axis, that every single muscle sees an increase in fat fraction over time. And the increases here are quite a bit larger because now the period that you look at is 6 years. But you can see that the range between patients is quite large, right? So there's quite a big spread in the measurements. And there's also a difference between the different muscles, where some muscles seem to go faster compared to others. As I mentioned in the beginning, it's important that for a biomarker correlates to disease progression, but also correlates to function, right? And here again, I've showed examples in different neuromuscular diseases. You'll notice that there's a lot of Duchenne in the presentation. That is partly because we study Duchenne a lot, but also because worldwide, there's a lot of attention for this disease. So this again is a study from the imaging DMD group, where they show that the modified group lower extremity score, so that's a functional scale, correlates or relates to the vastus lateralis fat fraction, where the higher the score, so the worse the function, the higher the fat fraction of the vastus lateralis. Also in IBM, this is a study by the group in London, you can see that the functional score here on the y-axis correlates negatively with the mean thigh fat fraction. So they took an average of the whole thigh, that the lower the score, the higher your fat fraction. Also in FSHD, again, so sorry, I cannot control how people make their figures. So here again, the fat fraction is on the y-axis and the functional score is on the x-axis, where you again see that the lower your score, the higher the fat fraction. So one important step that was made in Duchenne muscular dystrophy very recently, basically last year, is what I showed here are pure correlations to function, right? So you look at the fat fraction at a certain time and you look at the function at a certain time. However, if we want MRI to be used as a biomarker in clinical trials, one of the ideas is that it's actually more sensitive than function at that time, and also that we hope that it can predict future function. So one of the important steps that we made, and that several groups at the same time actually made, is to try to model these fat fractions. So I already showed in the study with Hoymans and all that all these muscles seem to show a similar sigmoidal trajectory, right? Where there you see a long time there's hardly any increase, and as soon as a muscle starts to increase its fat fraction, it goes almost linearly, and then it starts to slow down again. So here we looked at the vastus lateralis fat fraction in 2 different cohorts. So a cohort from Leiden and a cohort from Cincinnati, where all the patients were measured 1, 2, or 3 times. And we plotted all their fat fractions against age. And then you can actually model this whole disease trajectory with an S-curve. And then we interviewed these patients to ask them when they lost ambulation. Because the advantage of putting all these data on a curve is that you can actually model where their fat fraction will be in a couple of years. And then you can relate that fat fraction to the moment that they lost ambulation. So we can actually look back in time or look forward in time. The important step that was also made is that in this case, we took age into account into the relation, right? Because if in a progressive disease, any parameter that increases with age will always correlate with muscle function. In Duchenne, shoe size will correlate with muscle function. And we all know that shoe size is not a very good outcome measure in a clinical trial because it's not very likely to change with therapy. At least I hope it won't. So what we were able to show is that a higher fat fraction at any age, so that means that we took age into account, increases the risk to lose ambulation with a hazard ratio of 1.15, which is a statistical term. So this means that if you have a higher fat fraction at the age of 10, you have a higher risk of losing ambulation, independent of the effect of age. And imaging DMD, so the group in the US showed at about the same time a very similar thing, where they could also show that they plotted it in a different way. So they say the probability of retaining ambulation, so the fact that you keep your ambulation, is actually increased if you are on a different trajectory of your fat fraction increase, right? So these are the different percentiles of the different trajectories. So for us, it was really nice, right? That you actually, two groups independently of each other show the same thing, show the fact that a higher fat fraction at any age increases the risk to lose ambulation. So we've talked a lot about fat fraction so far, but in the end, it's not the fat that contracts, right? It's the skeletal muscle that contracts. So maybe it's actually not so logical to look at the fat, but we should look at the muscle which is still there. So if you look at this image, what we do when we analyze these data is actually we draw an MRI around the muscle and we look at the fat fraction of this part of the muscle. So in the dystrophic process, what happens, so of course, this is a very simplified schematic, but in the dystrophic process, you replace part of your muscle by fat. And we look at, so far, we've only looked at the fat fraction, but we have not looked at the area of muscle which is still there, which actually might, logically, it may be that's a much better outcome measure compared to the fat fraction. Right, so several people, of course, also looked at this. I'm sorry for this a little bit cluttered table, but you have to look at the muscle volume index here. So this column, and there you can see that the muscle contractile volume actually also correlates with function, right? So it correlates with the 4-stair climb, with the 6-minute walk distance, with the rise from the floor. So this is in DMD. And also a very recent study in late onset Pompe disease shows the same thing, right? Where the contractile CSA, so the amount of muscle tissue which is still there in controls, but also in late onset Pompe disease patients, actually correlates with muscle strength. So the larger your muscle, the stronger it is, both for the knee flexors and the knee extensions, the knee extensors. However, one of the things that was also apparent, because there are quite a number of people who did this and in different types of neuromuscular diseases, is that actually the remaining muscle tissue in these patients is not as strong as you would expect from a healthy control. So you see here on the x-axis the amount of muscle tissue which is left, on the y-axis the amount of force that muscle can deliver, and you can actually see that with the same amount of muscle or the same cross-sectional area, for instance at 100 here, the FSHD patients can actually deliver a lot less force, about 2,000 newtons compared to about 5,000 newtons compared to healthy controls. So this was found in FSHD patients. It was also found, Beatrice Walker found it in Duchenne patients, the same thing in the hamstrings. Lukken et al. From the Copenhagen group found the same thing in Becker patients, where actually in Becker patients, it hardly correlated at all, the amount of muscle tissue that you have with muscle torque in this case. And also in IBM patients, this was found, right? That with the same amount of muscle tissue, you can actually deliver less force. So in summary, for the fat fraction for this part, Quantitative MRI can measure the fat replacement of muscle tissue. I hope I've made that quite clear so far. This fat replacement increases with disease progression and or age, because sometimes that is the same thing, especially in progressive disease. Fat replacement differs both between and within muscles. There are moderate to high correlations to function, so in general above 0.65, although there are also studies that find lower correlations, and there are studies that find much higher correlations, but I did not want to go into full details here. And fat fraction can predict loss of ambulation, at least has been shown in Duchenne muscular dystrophy. However, if you remember the disease cascade that I showed earlier, we're looking at end-stage pathology rather than active disease. And that is why all the way at the beginning, when I showed the different contrasts that we could look at, so the edema, the muscle fiber size, the fibrosis, that is why there's still a lot of active research going on into looking into active disease parameters, right? Because we still don't know whether this end-stage pathology measures will, in the end, be the ones that respond to therapy, but we have good hopes. Another thing is that the quality of the remaining muscle tissue is lower, right? That's what I showed you in the previous slide. So even if we can stabilize the fat fraction, it's still a hypothesis that patients will also get stronger, right? And the only way to show that is with a therapy that works. So how about trial readiness? We've shown that fat fraction is related to function, is that we can measure it nicely with quantitative MRI. But if you want to perform a trial, it's important that your measure is also accurate and precise, and that it's reproducible, right? So the imaging DMD group did a very large, quite one of the largest studies into this, at least the ones that's been published in Duchenne muscular dystrophy. And what they showed that in a very well QC, so a very well quality controlled system, the reproducibility is high, right? So this is the day-to-day variation in so 29 Duchenne patients and 10 controls, where the black bar is day 1 and day 2 is the gray bar, and you can see that these measures are actually all quite close together. They also show that the coefficient of variation is reasonable. it's quite low. On the other hand, you can also see that there's a difference between the different centers. And what they also showed is that I did not go into that, but you can measure your fat fraction in 2 different ways. You can measure the fat fraction using MR spectroscopy, and you can measure the fat fraction using the Dixon sequence. And I've shown a lot of data from the Dixon sequence, but most of the data that I showed from the imaging DMD group were based on MR spectroscopy. But these 2 measures actually agree quite well, at least in Duchenne, right? So here's the line of identity. You can see that at the lower fat fractions, the MRI-based fat fraction overestimates it a little bit, but in general, it agrees quite well. Another important concept that it would be great if you listen to my talk today and you remember this concept is the standardized response mean. So the standardized response mean is the mean change over time divided by the standard deviation between subjects. So you will get a really high standardized response mean if your change over time is quite large and your variation between subjects is low. If you do not have a large change over time and you have a lot of variability between your subjects, you will find a low standardized response mean. And it's generally accepted that if you calculate the standardized response mean and you have a standardized response mean of higher than 0.8, then you have a high level of responsiveness to detect change. So basically what we're looking for is a biomarker with an SRM of higher than 0.8. So what was shown in Duchenne, again by the imaging DMD group, is that depending on the muscle that you're looking at, the fat fraction has a standardized response mean of 0.6 to 1.82 over 1 year. And what you can then do with this standardized response mean is actually calculate how many subjects you need in each group to detect the stabilization of disease progression with 80% power, right? That's depicted here in this table. And what they showed is that if you look at the vastus lateralis fat fraction, for instance, then if you would look across all ages and you would use vastus lateralis fat fraction as an outcome measure, you would only need 13 subjects per group to detect stabilization of disease progression. But for instance, if you would compare this to the 6-minute walking test, you would need 68. right? So MRI would be much more sensitive compared to the 6-minute walking test to detect this change. Well, you may have already noticed some other references here. So there are also a lot of other groups who use this methodology to look at their data. And Murphy et al. Showed that in LGMD2I, the fat fraction had an SRM of 0.53 to 1.28 over 6 years. So yeah, for part of the muscle, that was also higher than 0.8. While for function, there was quite a large variability. And for the CCSA, so the contractile CSA, I mentioned earlier, should we look at the muscle or should we look at the fat? The SRMs were actually all quite a little bit lower. We recently showed by Nienke van der Velde in I think it's just appeared in press, that for Becker, also the fat fraction was actually the most sensitive outcome measure. So for the fat fraction, the SRMs varied between 0.83 to 0.15 over a 2-year period. And for function, all these measures were actually lower. All the SRMs were lower. And also for CCSA, they were all lower than 0.8. So I usually don't really like to include quotes in my talk because I like to show images. But I really like this quote from Murphy et al. Where they state, if you compare muscle contractile area or fat fraction, that they stated that for every muscle group, the SRM for the CCSA is of smaller magnitude and the p-value less significant than for the respective fat fraction alone, indicating that the variability in the cross-sectional areas within the group outweighs the small yet progressive changes in fat fraction. So as I mentioned earlier, for the SRM, you need an increase over time and small variability between subjects. And because we all, at least this is my interpretation, because we all have different sizes, right? We all have different heights and lengths, and the variation, the between subject variation in cross-sectional area is just much larger compared to fat fraction, because fat fraction varies between 0 and 100. Right, so even though conceptually it would be more logical to look at the remaining muscle tissue, fat fraction is just more sensitive to detect change. So I already mentioned her before, Nienke, I think she's also online. We showed the same thing basically in Becker muscular dystrophy, where we performed a stepwise analysis of lots of different muscles and lots of different combinations of muscles. And yeah, I won't go through the whole stepwise analysis here, but none of the contractile cross-sectional area measures basically made it to the last step of our stepwise analysis. So we looked at SRM, we looked at correlation with baseline function, but you can read it in the paper. So what are the challenges in data analysis mainly? Well, there are proximal distal differences, right? So there are proximal distal differences in Duchenne, also in Becker. I noticed that I forgot to add a label here, but this is in Becker muscular dystrophy. And what do I mean with proximal distal differences? Well, the fat fraction is not homogeneously distributed over a muscle. So this is the peroneal muscle, where we see at the bottom, at the distal end, you see a higher fat fraction compared to the middle, and at the top it's higher again. So you can imagine, if you want to measure the fat fraction, that you have to be very consistent over time on where you place your slice. Because if you place your analysis slice here on the first measurement and then there on the measurement 2 years later, you might think that there's an increase in fat fraction, but there was not. So it's the same, maybe even stronger in FSHD, where you look here, if you look at the same muscle over different proximal distal areas. So here is the distal part of the upper leg, and this is the proximal part of the upper leg, where the distal part here, the vastus lateralis, is 24%, while at the bottom here, at the proximal end, it's only 11%. Also in Charcot-Marie Tooth disease, so this is not a quantitative imaging study, but a qualitative imaging study. So please do not look at the arrows because they wanted to point out something else. But you can see here that the fat fraction at the distal end is much higher compared to the proximal end. In Becker muscular dystrophy, if we look at the semitendinosus muscle, it's really quite extreme. While here at the proximal end, the semitendinosus muscle is almost completely normal. But at the more distal ends, it's almost completely replaced by fat, right? It's very hard to delineate the semitendinosus at that part. So another challenge in fat fraction imaging is the data analysis, right? So far, we've all manually delineated these muscles. So this is an example of lots of different slices and lots of different ROIs of the upper leg. And this is very time consuming, and you really need expert knowledge to do this. There is a high inter-rater correspondence, but still it's hours and hours and hours. So before going into this much more, I would just like to say that there's the solutions are on the way, right? So this is a study from the group in Paris where they looked at all different muscular dystrophies. So you can read all the names here. And I explained to you the concept of the SRM earlier. So that's all aligned here on the y-axis. And they used all kinds of different combinations. So they looked at the vastus lateralis, for instance, or the vastus lateralis, or the whole quadriceps groups, basically. Delineated separately, and then the whole quadriceps group showed drawn together. And what you can see is that if you look at a muscle group, in general, the SRMs are not lower compared to if you would look at a single muscle. So maybe we do not even need to spend all that time in delineating all the different muscles separately. And Nienke, I come back to the study again, actually showed the same thing, that the fat fraction for the whole thigh, the 3 center slices, actually performed the best of all the different ROIs that we drew. So we might need to spend all that time. On the other hand, there are also solutions, automatic solutions on the way with semi-automatic segmentation. So there are different approaches out there. There are semi-automatic segmentations, automatic segmentations, deep learning assisted. So I'm just showing the tool here from Francesco Santini, the Daphne network, which you can all try out online. There's also studies which use DTI as an input. But to be honest, this is really not my expertise. So I can recommend this review here where there's an overview of MR image segmentation strategies, and you can find everything there. So in summary, for the trial readiness, the reproducibility in a very well quality controlled system is quite high. The standardized response means that we measure are also high. There are proximal distal differences and there's time-intensive data analysis. However, solutions for this are on the way. There's still some caveats. So there's a need for specialized MR centers, and these specialized MR centers are not necessarily the place where the patients are. So there are different views on this, whether you should train all the centers or move the patients. So that the jury is still out on that one. Of course, there are contraindications for an MRI. As I explained in the beginning, it's a very big magnet. So a patient with a scoliosis operation will not be able to go into the scanner. Well, maybe they can go, but I'm not sure about the data quality. There is the patient burden of an MRI, right? If you only do a fat fracture measurement of a couple of minutes, it's not so high. But if you keep patients in the scanner for half an hour to an hour, it is perceived as a burden. And the data analysis so far is still an expert task. So if we look at the future, how do we go from individual studies to an approved outcome measure? Well, I hope you do not think that I'm going to provide a definite answer here, because I can already give you a spoiler alert, I will not, but I will show you where we are. So since I started in this field in 2007, 2008, there have been a lot of consensus and across stakeholder efforts on the use of MRI in clinical trials. I think it's been a promising outcome measure over the last decade. So one of the first ones that we had was in 2009. I think I was not even in the field back then. There was one in 2017. Then we had another one in 2015 in FSHD. There was one in Naarden again. So there's the de-risk consortium. So there were a lot of different efforts on this. But where we are now, I think is what is most important is that there are trials, positive trials, where MRI is used. So what these consensus efforts have resulted in is that at least the protocols that are used across these different studies are relatively similar. So the first positive trials are now starting to appear. This is not even now. This is a study from Pierre's group out of 2015 in Pompe's disease, where they showed that in Pompe patients that were treated, the increase in fat percentage per year was lower in muscles that had a normal muscle T2, so a normal inflammation edema measure, compared to patients that did not receive enzyme replacement therapy, right? So, but the difference, you can already see the difference is quite small. So you really need to be able to measure this correctly. A similar thing was shown in FSHD by the group in Nijmegen, where they gave patients cognitive behavioral therapy, and they also gave them physical therapy, so physical training. And there they also showed that the increase in fat fraction was a lot higher in untreated patients compared to patients that receive treatment. And the imaging D&D group again showed the difference between patients that received corticosteroids, so these are the blue bars, compared to patients that did not receive corticosteroids, where the increase in fat fraction over a year, no, over 6 months, I think, no, this is 1 year, where the increase over 1 year was a lot lower in corticosteroid naive patients compared to corticosteroid receiving patients. So without going into much detail, there is a difference between the FDA, who approves medications in the US, and the EMA, who does it in Europe. So the FDA really explicitly said that they encourage sponsors to consider the use of other biomarkers, such as those measured with magnetic resonance imaging or magnetic resonance spectroscopy. And the position of the EMA seems less explicit, but there are ongoing conversations with the FDA and with the EMA on approving MRI as a biomarker. So very recently, like 2 or 3 weeks ago, there were 2 trials, actually sponsor-initiated trials, that showed a positive response on the MRI. So they did not meet the primary endpoint. So in this case, for the Fulcrum trial in FSHD, the primary endpoint, the change in DUX4-driven gene expression, was not met. However, they did show a decreased muscle fat infiltration and also functional measures. And also very recently, it's a pharmaco that also included imaging in their trial. Also, that study also did not met the primary endpoint, but they also showed that the fat fraction actually did not increase as much in the, it actually hardly increased at all in the Becker muscular dystrophy patients that received Givinostat compared to the ones that were on placebo. So in conclusion, quantitative MRI is a promising surrogate outcome measure in clinical trials in neuromuscular diseases because it has a high reproducibility and a high sensitivity to detect change, and because there's a relation to clinically meaningful events. The very positive thing, at least for me, was that the first positive trials are starting to appear. So there are pharmaceutical companies that take imaging into account in their clinical trials. But to really go further and to go to the FDA and the EMA, we really need involvement of specialized parties, so not just the academics and or sponsors for the next step. So with that, I would like to thank you for your attention, thank all of these people, which I'm not sure if I mentioned everybody, and alert you to the MyoMRI conference, which we will host in the fall this year, together with Pierre and together with the whole MyoMRI committee. And the abstract deadline of that conference is September 1st. Thank you.
Thank you very much, Hermine. Brilliant presentation. I want to remind everybody that the summer school webinars are a collaboration between Treat-NMD and Euro-NMD, which I didn't say at the beginning, as usual. So everybody can unmute yourself and talk if you want. I don't see any questions in Q&A. So to kickstart, as usual, I don't know if Pierre has more intelligent questions than me. I'm sure he has. But to kickstart, I'm going to ask one. I think that the data analysis of MRI is just lacking a lot of automation, isn't it? Because when you start having possibilities of doing volumetric acquisition and by defining the regions of interest, you can have those same fractions of fat calculated for the whole muscle. But I was a bit disappointed when you said that if you have a slice and you calculate the fraction of fat of a complete thigh, that's more sensible to change that a more targeted approach, because my idea is that basically one of the things that enables diagnosis through MRI in neuromuscular disease is exactly the different patterns of involvement. Would you care to give us some ideas about that, please?
Yeah, sure. Yeah, I would. So I think that, I would like to say, so the disappointment, I'm not sure if disappointed was the right word, because we were actually quite happy, because that might mean that you do not have to delineate every single muscle. So what I think lies behind it is exactly the difference between patients and the difference between the disease stages that they are in. That in some muscles, that some patients, that particular muscle is already affected a lot, while in others it is not. So the variability is quite high. And if you lump them all together, then you might get rid of a little bit of that variation. I think to be the most sensitive, you would need to decide for each patient what the muscle is that is going to change the most. However, to relate that muscle then to function is more difficult, right? So for the vastus lateralis, I can imagine that it's related to function because it's an important muscle in the upper leg. To relate only the semitendinosus or only the gracilis to a certain function is more difficult. So I think that there's two different ways, right? If you want to relate muscle fat fraction to function, I think it makes sense to lump a lot of muscles together. If you only want to look at which biomarker is the most sensitive to change, then you want to look at a single muscle. But because the EMA and the FDA, and in the end, of course, also the patients, because it makes sense, want to look at function, you not only want the biomarker to change, you want the function to change. It makes sense to lump them together.
That's clear. Pierre, do you have any comments? Or?
Yes, well, do you hear me well?
Yes.
Yeah. Okay, well, thanks a lot, Herman, for this excellent webinar. I think you have covered what is really important for clinician colleagues. And the point you alluded to, Antonio, I think is a critical one, because what you said is just what we taught. Because the fact that a global analysis might beat what we could say the preferred muscle is totally counterintuitive. The first thing is that we are not dealing with diagnosis, so patterns is not a question here. And I think, as Herman said, making a global analysis, I mean, we also suppress a lot of small variations that we induced and that can impact on the so-called standardized response mean. So I hope that this concept of going global for clinical study will probably impose itself in the future, because it will greatly simplify things. And even though we are pushing that, for the sake of honesty, I have to say that the idea, I think first was pushed forward by the Marseille group, and then it was taken over by Newcastle, and it's Herman Reingold who very patiently looked at many diseases and came to the conclusion that the global SRM is very important. I have a question, and it's really the challenge for me. We need to convince the regulatory agencies. And I think that we have a large body of evidence showing that, well, muscle destruction for dystrophy and also for other disease precedes the change in function and the clinical symptoms. There's, I think, really a body of evidence for that. Now, if I want to play the devil advocate, we need to prove that when we stop the muscle destruction, as we can show it with imaging, and the more and more cases, well, it is not obvious and it is not systematic that it will announce and it really predict a protection of function and a delay in the symptoms. I think it's impossible to, from the natural history, to affirm that. And I don't know what is your position. I'm rather pessimistic about that, because if the regulatory agency really want to know that, it will mean that we need many years to start from these ongoing studies showing that, well, the muscle destruction is prevented to some extent, to the point that the clinical symptoms are delayed or improved. If we follow the natural history, it will take many years, and it will be a pity for the patient.
Yep. No, I fully agree. But what my understanding is, but I have not talked to the EMA about this yet, but what I hear is that the EMA is willing to accept MRI as an outcome measure if all the other measurements also go into the same direction, right? So even if the functional outcome measure does not reach significance, but it shows an improvement and MRI shows significance, then they will accept it as an outcome measure. But we still need, I fully agree. I think based on natural history, I'm not sure if that's going to happen. You need a positive trial and you need a good drug. and I'm an MRI person, so I will not make the drugs. So we need good people to make these drugs. And I see it as our role and my role to at least convince the sponsors that we think that this measure can be measured well, reproducible, in a good way, and that they will include MRI into their trials. And then indeed we need to wait until a sponsor makes a medicine, makes a therapy where it's actually shown that it works, and that if you would have used the MRI rather than the functional test as a primary outcome, you would have needed half of the patients. And I hope that will not take 5 years, but I don't know.
So I wanted to ask you about FSHD, if you don't mind. So it's that kind of disease where the MRI is abnormal before the function is affected, and you have early signs of inflammation before you have atrophy. So my question is dual side. Before we see inflammation, do you know of any other way of predicting that muscle will be affected? And do you think that the window between seeing inflammation and going downwards to atrophy is enough for us to plan any intervention in that space or not?
That's a challenging one. I would say that in FSHD, so if I remember the Fulcrum trial correctly, they focused, I think, also on muscles which had intermediate fat fraction. I'm not sure if they also focused on the muscles that had stir abnormalities. But you're basically asking if there's something that predicts that appears prior to the stir abnormalities, right?
Yes.
Yeah. I don't know. What I know of the studies from the Copenhagen group is that they mainly looked whether the stir abnormalities indeed always increase to lead to fat replacement, which is also not it's not a very straightforward relation. I only know that well, Pierre does the same and we do the same. We're always looking for other measures to look at those active muscles, and I'm not sure whether that will be metabolism. So we've looked a lot at phosphorus metabolism. I know that the group in Basel is also looking at phase contrast MRI, so looking at functional measures. I think it's just a matter of keeping on developing these things and trying them in patients to see, because I wish I could give you a better answer, but I don't know.
Thank you. It's a good enough one.
I don't know if Zeni has anything. I don't know if everybody can talk, but I don't know if Zeni has anything to. I know that she's on. At least her picture is online.
Yes, she is.
Yeah. Well, we are still investigating it, but that's our hope that maybe functional measures could come before. But I cannot. Unfortunately, I cannot give a confident answer yet.
Thank you.
Okay, any more questions? I don't see questions in Q&A. So we are about at the end. So I would like very much to thank you, Ermin, for this splendid exposition presentation, and I think that it has lots of lessons to learn, and that will incite discussions and progression. And I hope that everybody who attended today or will attend in the future in the form of on-demand webinar will be able to get ideas from here to make progress in research and for the profit of our patients, of course. Okay, so thank you very much, and hope to talk soon.